So we're going to talk about thoracic trauma for the next couple minutes, and we'll get you out of here in time for lunch and get some rest and start the weekend early. Trauma alert? AMA? What happened to this guy?
He's dead.
Should we pull it out?
No.
Halloween.
Gunshot wound to the torso. It's a sucking chest wound. We'll go over that in a few minutes. X-ray of someone with a GSW, some buckshot. This is a nice direct view of a cardiac contusion. So basically, it's a bruise of the heart. Right? It's a blunt trauma to the heart. This is something you guys probably won't be seeing that often from this view, at least. But you may be seeing multiple pneumothoraces in the future. So what do you see here? This normal lung tissues. See the little lines going out all the way to the edges. See how there's more lines here? It's probably a little bit of a cardiac contusion. What's that? It's probably some fluid, hemothorax. Cardiac, pulmonary contusion. Sorry, pulmonary contusion, and then that black right there is a pneumothorax. Exactly, it's air. It's a pericardial effusion. It's fluid outside in the sac that covers the heart. And this is a diaphragmatic rupture where you see the stomach. Remember, this is a view from the feet up, right? So this is the sternum, that's the back, the spine. You're looking at the feet up. Heart, and that's the stomach, and it's just higher up. So the diaphragm is an earlier cut than you have the stomach. So it's actually, the diaphragm has a rent in it, and the stomach's herniated through. Tracheal disruption. Something that's relatively uncommon, but when it occurs, you really do need to be very careful with your airway management. Why? If you intubate the patient, what's going to happen? Intubate the patient here. It might be okay, right? The tube goes down. Intubate the patient here. Tube goes down, and then what happens? Right. Might come out here, here. Problem is, you crite the patient. What happens? Crite the patient. Put the tube in here, comes out here, comes out there. So you just have to be super careful, and it's really tricky. It's really tricky. I mean, you can try to do a trach, but you have to get proximal to the injury. It's really dicey situation. So here's a case scenario: 27-year-old male brought to a trauma center. He was an unrestrained driver in a high-speed frontal impact collision. There was a prolonged extrication at the scene. Blood pressure 90/70, heart rate 110, respiratory rate 36. His GCS is 15. He has that going for him, and a patent airway. So what features suggest that this patient has a thoracic, may have a thoracic injury? So tachypnea, right? Very fast respiratory rate, tachycardia. Blood pressure, it's low. At what blood pressure, or better yet, how much of your blood volume can you lose before you start having hypotension? In other words, once you start having shock and blood pressure drop, how much blood have you already lost? And especially in a 27-year-old male. Right? You can lose about 30% of your blood before you start having hypotension. So in other words, if we wait for a patient to drop their blood pressure before we start treating them for hypovolemic shock, we're already behind the 8 ball. Okay? And the other poor prognostic sign is the mechanism, right? It's an unrestrained driver in a high-speed frontal impact collision. Certainly worry about head injury as well as thoracic injury, probably abdominal injury. So our objectives. In general, in ATLS, it's identify and treat the life-threatening injuries found during the primary and secondary survey. Okay? In the pre-hospital setting, it's really the key things, and we'll go over these, are going to be the primary survey. There's a couple things that you can diagnose in the field and treat and do something about. Okay? So thoracic trauma is interesting in that the vast majority of thoracic trauma, either blunt or penetrating, mostly blunt, actually can be taken care of with a very few simple maneuvers. Okay? Intubation, and airway control, IV access and blood products and crystalloid, and possibly a chest tube. Okay, so probably about 80% of all thoracic trauma can be taken care of. 80–85% of all thoracic trauma can be taken care of with those few simple maneuvers. Blunt, less than 10% of blunt thoracic trauma require a thoracotomy. Penetrating, someone getting stabbed or shot in the chest, actually only 15 to 30% require thoracotomy. Again, nothing, that means what, 70% to 85% only require a chest tube, or less. And most life-threatening injuries are identified during the primary survey. And again, this is going to be the key. In the pre-hospital setting, you have to identify some of these life-threatening injuries and act on them in the primary survey. So what are the immediately life-threatening chest injuries? The laryngotracheal injury or airway obstruction, right? Just like we saw before, like a tracheal disruption, tension pneumothorax, and an open pneumothorax. So these pneumothoraces are differentiated from a simple pneumothorax, and we'll talk about that in a few minutes. Flail chest and pulmonary contusion, certainly bad. There are certainly bad injuries. You don't want to have them, but to diagnose these in the field, it's going to be a little tricky and not necessarily the life-threatening injury. All right. Massive hemothorax and cardiac tamponade are very bad, very deadly, and need to be treated immediately. So what are the physiologic consequences of chest injury? Okay. What does breathing do for you? Okay, I'll take the simple one. I'll take the easy one. So breathing gets oxygen into your body, right? So you can perfuse your tissues and bring oxygen and nutrients to your tissues. But what else does it do? What else does breathing do? Gets rid of your CO2, right? So ventilation, getting rid of the CO2. So when you have a chest injury, you can have a decrease in your oxygen intake, but also a decrease in your CO2 expiration. Okay, so you build up a respiratory acidosis because you build up your CO2. In addition, you have a metabolic acidosis because of the lack of oxygen. So it's sort of a bad combination. It's a bad cycle. And then inadequate tissue perfusion in general because of hypovolemia and bleeding. So airway obstruction, it's actually relatively uncommon, but it does happen. It's something you need to be aware of. You can have a tracheal disruption or tracheal or orotracheal or pharyngeal obstruction. Hoarseness, if they are speaking or if they are having any attempts at speech, you can sometimes hear some hoarseness. Sub-Q emphysema, and then manage it as during the primary survey, which is intubation, possibly cric. But you got to be really careful. You got to be really careful with intubation with people with maxillofacial fractures or possible tracheal injury. You always have to have some kind of backup with you, because when you take a look, you never know what you're going to see. A tension pneumothorax. Okay, let's talk about a simple pneumothorax first. Okay, a simple pneumothorax is not necessarily a life threat right then and there in the field, but it can develop into a tension. So a simple pneumothorax is what? It's air outside of the lung, but in the chest cavity. Right? There's two linings in the chest cavity. Right? The two there's the parietal pleura and the visceral pleura, and usually those pleura